The burden of obesity-related cancer does not fall evenly across the American population. Black and Native American communities suffer significantly higher mortality rates, not simply because of genetic predisposition or lifestyle choices, but because of deeply rooted social determinants of health and structural inequities that have gone unaddressed for generations. These disparities are not accidental. They are the direct result of systemic neglect, institutional racism, and policy failures that continue to shape who lives, who gets sick, and who dies. For Black Americans, obesity is both more prevalent and more dangerous. Historical injustices, redlining, segregation, underinvestment in Black neighborhoods have created environments with limited access to healthy food, safe recreational spaces, and quality healthcare. Fast food outlets are abundant, while supermarkets with fresh produce are rare. Schools are underfunded, jobs are often lower paying, and healthcare providers are less accessible or less trusted due to decades of discrimination and mistreatment. This toxic mix leads to a higher risk of obesity-related cancers such as breast, colorectal, prostate, and pancreatic cancer. And when cancer strikes, outcomes are worse. Black patients are more likely to be diagnosed at later stages and less likely to receive timely, aggressive treatment. Even when insurance status is equalized, racial disparities in care persist, highlighting the devastating role that bias and institutional barriers play in survival. The case is equally stark for Native American populations. These communities, often living in rural or reservation settings, face some of the worst health statistics in the country. Obesity rates are among the highest, driven by historical trauma, poverty, lack of access to nutritious food, and underfunded healthcare systems. Cancer prevention services are scarce, screenings are often missed, and when care is available, it's frequently substandard. Native Americans have some of the lowest cancer survival rates of any ethnic group in the U.S., a fact that rarely makes headlines but reflects a profound failure of responsibility. For both Black and Native American groups, chronic stress plays a hidden but deadly role. Living under constant economic hardship, racism, and community disinvestment activates biological stress pathways that increase inflammation and worsen metabolic health, thereby compounding the risk of both obesity and cancer. This is not just a matter of poor lifestyle choices. It is the biological embodiment of inequality. Even public health campaigns often fail these communities. Messaging around cancer prevention tends to be generic and culturally detached. Few programs are tailored to the specific histories, languages, or realities of Black or Indigenous life. Funding for prevention programs is uneven, research often excludes diverse populations, and the medical system rarely hires from the communities most affected, leading to mistrust and lower engagement. And when it comes to solutions, the national focus remains too narrow. While scientific research continues to uncover how obesity fuels cancer biologically, far less effort is directed toward addressing the social and political structures that make obesity inevitable in marginalized groups. The result is a cruel cycle: higher risk, worse access, poorer outcomes, and little change. The warning here is urgent and unavoidable. If obesity-related cancer is allowed to continue rising unchecked, it will deepen racial health disparities that are already catastrophic. Any serious effort to fight cancer must go beyond hospitals and into the policies, neighborhoods, and histories that shape who gets sick in the first place. Without confronting structural inequity head-on, we will never solve the problem. We will only keep watching it kill the same communities over and over again.